Hello, everyone. I'm Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and this is EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us, especially in clinical practice and sometimes professional issues and others. But today, my guest is Dr. Jennial Palmer, who has a background in pharmaceutical science, but an MD, PhD from the Medical College of Georgia. We're here to talk about procalcitonin. Tell me a little bit about procalcitonin use in the emergency department.
Yes, sir. Thank you for having me for this topic. It's near and dear to me. Procalcitonin is a test I use daily, multiple times a day. Every shift I work, I utilize it. It's a great tool that is available to emergency physicians, most of the emergency physicians, and is widely becoming more and more available to even rural parts of United States. And it's interesting because it does begin to sort of help us differentiate between viral infections and bacterial infections. And it's one of the tools that we can implement to direct us in the right direction towards either a bacterial infection or a viral infection. And we can discuss details as you'd like, but
Yeah,
essentially that's the core of my belief about procalcitonin.
you're familiar with the clinical trials using it in the emergency department.
Yes, sir. Yes, sir. Yeah, there's a number of clinical trials that have been performed regarding procalcitonin. Its specific use in lower respiratory tract infection is very well documented, and in multiple websites and resources now actually utilize these trials, and they're recommending procalcitonin use based on these clinical trials. So procalcitonin in lower respiratory tract infection, along with in sepsis, is being recommended by majority of the guidelines, and along with emergency medicine protocols, now starting to implement it and utilize it. So yes, absolutely.
So procalcitonin has been utilized for some time now in looking at sepsis, but you're saying it has wider applications than just lower respiratory tract infections.
The clinical trials begin to come about maybe 4 or 5 years ago, begin to appear in more of a multi-standard blinded studies, and essentially showing what we just discussed, how procalcitonin could be utilized in lower respiratory tract infections along with sepsis, and sort of further clarify from emergency room perspective, we can start the procalcitonin testing, and obviously its elevation is significantly, it helps us elucidate bacterial versus viral infection, along with the overall picture, like such as fever, cough, patient's blood pressure, patient's other vital signs pointing towards bacterial infection, along with procalcitonin, kind of helps us guide our antibiotic management. And overall, this procalcitonin use it comes down to antibiotic stewardship, right? We
Sure.
all want to, that's all we want to do is everyone, all the physicians, no matter where you're working, we all understand that we all overprescribe antibiotics just because
Yep.
we don't know. We don't know.
Right.
Majority of times it's viral versus bacterial infections. So all of this boils down to that is antibiotic stewardship. And with procalcitonin, I myself have tremendously reduced my antibiotic prescription, and I can, we'll talk about how and in what sense, but it really does add one more large piece of the puzzle on how to direct antibiotic stewardship and take it in one direction versus other.
Fascinating. Well, obviously, the last 2 years we have been inundated with a particular viral infection of the lungs, which has given us pause and obviously a great deal of fear, and that's COVID. Talk to us a little bit about the trials that discuss COVID and procalcitonin elevations in the patients that we're trying to sort out. Is it COVID? Is it bacterial pneumonia?
This is when I actually became a true believer of procalcitonin as well. In my own practice, almost every patient I've dealt with that had suspicion for COVID, which is, I've been working throughout the whole pandemic, so it's hundreds and thousands of patients, and I've ordered procalcitonin on majority of the patients, and I've yet to find procalcitonin elevation in purely COVID positive patients without a co-infection. Now, when procalcitonin has been elevated in my case, it makes me think, yeah, I need to look farther and look for a co-infection, a bacterial infection. And as you know, I'm in South Florida. We have the highest concentration of centenarians and
Sure.
and nursing homes. So our patients, this is the typical population where you have sepsis, you have lower respiratory tract infection, and really the infectious diseases are what sort of drives most of our care. And that has shown us that if the procalcitonin is elevated, that there's definitely a risk for bacterial infection, and sort of if COVID is positive, sort of look for a secondary co-infection. And
Right.
I've done CAT scans on patients that have had procalcitonin elevation, and there's consolidations, there's infectious process beyond just COVID, and we treat accordingly. So the antibiotic stewardship again has been guided in COVID in my practice, and I'll discuss some clinical trials that have also shown that pure COVID infections, procalcitonin remains low. Co-infection and bacterial infection, procalcitonin is elevated.
Okay.
Yeah.
Share with us, you mentioned that you would give us some overviews of some of the studies that can you do that for us?
Yeah, absolutely. So one of the studies, I'll just highlight the title of it: high procalcitonin level associated with increased intensive care admission and mortality in patients with COVID infection in emergency department.
Mm-hmm.
And their conclusion at the end was that when procalcitonin is elevated with patient populations that have COVID, their likelihood of getting admitted to the ICU is greater, along with co-infections, with bacterial infections such as lower respiratory tract infection, sepsis, what have you. That's one of the trials, and that was published just here in a few months ago in 2022. There is characteristics of patients with procalcitonin measurement during early diagnosis of COVID positive patients. Negative predictor value of procalcitonin to rule out bacterial respiratory co-infection in critically ill COVID-19 patients. And this study actually was probably one of the largest ones. There was 4,600 patients that were tested.
Wow.
4,600 patients that were tested, and baseline values for procalcitonin cutoff was about less than 0.3 nanograms per milliliter, which is pretty much standard. And they concluded that, and I'll read it right off their website, baseline values of procalcitonin less than 0.3 may be useful to rule out bacterial co-infection, providing clinicians a valuable tool to guide antibiotic stewardship and allowing unjustified overuse of antibiotics observed during the pandemic. Additionally, they add a little bit more that procalcitonin levels greater than 0.5 may predict worsening outcomes. 0.5 is what we use in my emergency department, but 0.3 to 0.5 range is sort of a dangerous level. Anything higher than 0.3, 0.5, and you really want to worry about bacterial infection. More specifically, from all the guidelines, lower respiratory tract infections and sepsis.
Fascinating, because I know that with so many patients showing up with COVID, it's very easy to reflexively only see COVID, or on the other hand,
Right.
be reflexive or be protocol driven, such that patient shows up and you reflexively overprescribe antibiotics. You can make the mistake going both directions. And one of our goal, of course, and with all the problems with overprescribing, particularly in the elderly, and so we can't ignore the complications that are associated with overprescribing of antibiotics. So you really don't want to give an elderly patient antibiotics if they don't require it. And
absolutely.
And so what your study is showing is that procalcitonin is a very, very sensitive indicator of when not only are they COVID positive, but they also have a co-infection, which would then signal a higher intensity of care, but also an appropriate level of antibiotic therapy. So that's fascinating.
Yeah, absolutely. And I just wanted to add that procalcitonin, for listeners that are not aware of how it's synthesized, synthesized in our own body, and it's only elevated in any kind of systemic inflammatory states. Particularly, it needs to be some kind of bacterial endotoxin
Right.
causing TNF alpha and these cytokines specifically triggered by bacterial infections that would cause a rise in procalcitonin, which is later cleaved to become calcitonin, which we're not obviously clearly interested in that. But procalcitonin is synthesized by pretty much every cell in our body upon a bacterial infection. And specifically, when viral infections happen, when we look at in vitro studies, there's a pathway that actually inhibits procalcitonin synthesis and secretion. So really, if you have a viral infection, it's purely viral infection, procalcitonin level is very, very unlikely to get elevated unless they have like a shock from a different reason, from pancreatic, source or what have you, or muscle breakdown, what have you. That procalcitonin is unlikely to get elevated in anything but a viral infection, at least in a mechanistic way. And now we're finding out more and more that these trials and the studies that are done in multi-centered locations and blinded, they're also finding that yes, procalcitonin is what it seems to be. And again, another tool to protect a antibiotic stewardship culture that we all starting to develop.
Yeah. Now, the problem that, I've spent my career practicing in smaller community hospitals. And so
Sure.
we always heard from, we've heard about procalcitonin levels, for many, many years. But many of the places that I worked at didn't have the ability to measure procalcitonin levels. And are you saying then that more and more labs are able to do this?
Absolutely, yeah. So I'm an emergency medicine physician here in South Florida, and we were one of the first hospitals to get procalcitonin. I believe about 3.5, 4 years ago. My wife is also an emergency medicine physician, and she is maybe 45 minutes from. She works 45 minutes from where I work. And their hospital, despite it being larger than us, did not have procalcitonin at that time,
Yeah.
which they have acquired it also. I have colleagues all around the city and all around the area, which again, they're starting to acquire procalcitonin. So it is becoming more readily available. And as biomeri, biofire, essentially we're getting the word out and getting more of these medical directors aware of these this test. People are likely to adapt this because if you can have 5 out of 100 patients that come into the hospital, that come into the ER a day, and you prevent 5 long-term antibiotic use, like 5 courses of antibiotics, that alone is going to save admitted hospital patients so much more, just in terms of the cost. It would save. Not to mention their elderly patient, as you mentioned, the antibiotics falls or misguided antibiotics would
Sure.
cause number on their GI tract and their overall health and overall antibiotic stewardship. So again, the cost of procalcitonin is to me is very minuscule compared to the benefits that would provide, even for rural hospitals who again are less likely to have resources and larger ICUs where they might be transferring patients. So
Right.
it is absolutely necessary, I feel like, for sort of rural environment, larger environment, sort of everywhere, because we can all work together.
Sure.
I have a colleague in ICU, which I was communicating with yesterday, and essentially, I was trying to, before this talk, I was trying to find out how they were kind of utilizing it, and exactly how we saw it in some of these clinical trials, that not only do we get to prevent antibiotics, starting to prevent the antibiotic use from the ER, but if antibiotic is started in the ER and the procalcitonin is elevated, then the duration of antibiotic use is also reduced significantly when you use procalcitonin in an appropriate way, because the procalcitonin will dramatically reduce as bacterial burden reduces in the body. So as the bacterial burden reduces in the body, procalcitonin level drops. My colleagues in ICU and in the medical wards are stopping the antibiotics. Essentially, lot sooner than we would have if procalcitonin wasn't utilized.
So it's not just a diagnostic tool, but it's also a way to gauge the level of infection and in the patient.
Absolutely, level of infection, exactly, and the duration of antibiotics, which is, really there's not any clear guidelines on how many days a lower respiratory tract infection patient should receive antibiotics, inpatient versus outpatient. It's sort of 5 7 days, 10 days. It all depends on comorbidities, age of the patient. But with procalcitonin, you sort of feel more confident. Again, you take everything else in the picture. Like, I'm not just ordering a chest X-ray and procalcitonin. I'm ordering everything else and looking at the patient as a whole, along with comorbidities, what medications they're on, cancer, etc., and sort of guide the antibiotic use based on one more tool.
Hey, you mentioned our sponsor for this podcast is BioFire, and there's a very practical aspect of being able to test for this. Can you speak to that? What sort of capability is what's the hurdle to being able to test for procalcitonin? A different machine, a different reagent, what is the requirement?
Yeah, really the hurdle is quite small. It's really just the medical directors and the laboratory directors need to get together and decide if they would like procalcitonin in their hospital, emergency rooms, ICUs, etc. Because BioFire will not only provide the machines that needs to be used to test procalcitonin, but reagents, etc. Everything gets set up as soon as the hospital decides, okay, we want to have procalcitonin. And obviously, don't quote me on this, but they might provide a machine or two to start things with, and
right.
And that's all it takes is a machine or two. Really, you don't need a whole area in the lab. It's just a small machine that runs this thing.
Yeah.
And in my ER, before maybe 4 years ago, the procalcitonin was almost like an overnight study.
Yeah,
BioFire,
right. That's my experience was that
yes.
You could get procalcitonin, but by the time you got it back, it was really irrelevant. It took a long time to get it, and so a lot of people weren't early adopters because they said, "Oh, okay, well, it's not really going to guide my treatment." And what you're saying is that BioFire has put it within range of being really helpful to the emergency department.
Oh yeah, absolutely. Not just within range. It's quick. It's sometimes it comes faster than my urinalysis. I order procalcitonin on patients with obviously suspected bacterial infection, and is within an hour the test comes back. And I hold antibiotics until then. In majority of the cases, unless there's clear cut X-ray or finding that or my lung sounds are very clearly directing me in one direction or the other, I'm holding antibiotics until procalcitonin level comes, and only after that I begin the antibiotics. Or for some reason there's an error in the blood draw, the nurses are having a hard time getting the blood draw, or there's a delay, maybe I will start the antibiotics. Procalcitonin comes back later because of blood draw delay or what have you. I'll tell the inpatient team, they're like, look, hey, procalcitonin has not been returned yet. I did start empiric antibiotics based on the overall picture.
Sure.
But obviously, and my colleagues upstairs are very happy. They're like, yeah, we'll take care of it. And they typically discontinue antibiotics if the level is clearly low and viral infection is more likely. So yeah, now there's really no reason people should not be using this. People should be using this because it's readily available, it's fast, it's available, and BioFire, BioMary, these guys will provide everything you need in your laboratory for it to be run.
Fantastic. So if you're a viewer and you're familiar with procalcitonin, but only as a research tool, and kind of said if it's not available in your hospital, that's for the tertiary care hospitals and locations, university hospitals. That's kind of where I never ordered procalcitons because it wasn't available to me, and my excuse for that was to say that well, that's for the tertiary care centers, and now BioFire basically has placed that within range for any hospital. And what Dr. Palmer is actually alluding to is that it is a very, very good tool to fine-tune your therapy for people who come in with lower respiratory tract infections, even ones that are COVID positive that may in fact be co-infected with a bacterial infection. So it's a very, very useful tool. So
yeah, absolutely. And I wanted to add one more thing before our time is up. Is there is some discrepancy. So recent literature research that I performed, there's about 8 to 9 papers pro calcitonin, and there's one or two papers here and there that would say that, hey, there was no difference, and we don't know if procalcitonin and further studies are required. And I've looked at these studies. They have sort of found procalcitonin to be sort of like equivocal or not as diagnostic, and the majority of the time there's discrepancies in several factors, including the cutoff value they're using instead of the 0.3 to 0.5 range that's recommended. They're using a different cutoff value. There's the implementation of the protocols that they have, when to start antibiotics, the protocol adherence that they had in the study, the assays that were used in these studies. They were all different. These aspects, they were all different. So if the guidelines are followed properly, the right cutoffs are used, I believe majority of these studies would find an advantage. So it some discrepancy that's out there, and I believe, obviously I have a PhD. I don't believe anything until I really go deep into everything, right? I mean, that's just my mindset. I did it for 5 years, and everything I sort of dive in really deep to make sure that I believe what I'm using is gonna help the patients overall. And my deep dive is what I ended up finding is the discrepancy is there, and there are some clinicians that I know, and a good friend of mine, they're good doctors. They're like, no, procalcitonin, I'm never going to use it. I don't know what it is, but again, it is something that you have to understand. The research are coming out, clinical studies are coming out, and you have to adapt to the new sort of environment of antibiotic stewardship. And really, the data is clear.
I see. Yeah, you might take a strong position and say procalcitonin is my hard indicator that antibiotics are necessary. You may find patients that the procalcitonin level is equivocal, like you say, 0.3 to 0.5 in that gray zone, in which case it would be sort of instructive, but not necessarily a hard indicator. You might view it as it's helpful but not determinative. But there is very little doubt that procalcitonin elevation is going to guide you toward antibiotics, and low procalcitonin levels are going to guide you away from antibiotics. And so, I mean, you can view it as strongly as you feel the evidence is, but you can't ignore it. The point of it is you can't ignore it.
You can't ignore the evidence. Yeah, and in 2022, you can just go on Google Scholar or PubMed and look at these scholarly articles, and there's a number of them. Then I'll name a couple more. Outside of lower respiratory tract infection and sepsis, there are studies that showing extrapulmonary applications of procalcitonin. For example, this one they're saying, for meningitis, procalcitonin could distinguish bacterial from viral meningitis. It's literally this is in their headline. This is in their secondary title. Obviously, there's also increased use of procalcitonin in pediatric population, especially the step-by-step protocol, which is obviously very much utilized in pediatric emergency departments and pediatric ICUs. And in their guidelines, procalcitonin is there. It's one of the items that need to be elevated along with several other items. So in pediatric patients, let me see, I think I read an article on a sickle cell patients that sickle cell patients obviously very complicated because of their medical condition, but they have vaso-occlusive crisis, just vaso-occlusive crisis across their back or legs, and it will cause a little bit of elevation in temperature. And there's a study that showed that procalcitonin level checked in sickle cell disease patients will help differentiate between vaso-occlusive crisis or viral infection from a true bacterial infection that, again, the sickle cell patients could have. So its application is getting broadly more and more broaden across bacterial infections outside of the pulmonary and extrapulmonary areas now. And it's great to see that bioMérieux, biofire have made it so easy to use it now that it's like I said, I order it daily, multiple patients.
Yeah.
And it helps really hone in on the antibiotic stewardship that I think everybody ought to be doing it.
Thanks. Okay, that's been a very insightful instruction, and thank you for your coming onto the program today. Everyone, if you're in a community hospital like the ones that I always practice with, and maybe that hasn't always been on your radar, maybe you ought to take another look at it. And it looks like it's not only helpful, but it's also probably within reach with this with what biofire is offering. So I hope you'll take a look at it. And thank you everyone for joining EP Talk, the place where emergency physicians come to talk about things that are important to us. Thank you.